Sir, we are live now. With all your permission, I'm starting this session. Hello, sir. Can you hear me?
Please go ahead.
Yeah. Good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker, doctor with great honor, none other than Dr. Abhyudaya Verma, sir. Let me share some of the achievement of this, sir. Sir has done MBBS, MD in Medicine, DNB, FACE, and Associate Professor at the Department of Endocrinology at Index Medical College, Indore. And today, sir is going to discuss on a topic, primary aldosteronism-induced hypertension. Let me tell you overview of the topic before starting this session. In this session, the sir will discuss about the diagnosis and evolution, treatment option, and complication and adverse effect. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you, Mr. Faraz, and good evening, all my dear friends and respected colleagues. Friends, we all know that hypertension is a very big problem nowadays. A lot of people are suffering from hypertension, and more than half of them, they are either not treated properly or not even diagnosed. And as we know that this is a silent killer with not a lot of symptoms till the organ damage happens. So to create awareness, to create more insights into the management of hypertension, today I would be talking specifically about primary aldosteronism-induced hypertension, which is again quite common but very easily neglected part of hypertension management. So as I said, hypertension is the major risk factor for cardiovascular diseases, and more than 30% of our adult population is suffering from hypertension. So you can see how common this problem is. Most of the cases, the hypertension is primary, which means it is a essential hypertension or a idiopathic hypertension, which we say a routine hypertension in our general practice. But our subgroup of approximately 10 to 15% of these patients, they have a secondary hypertension. It means there is some cause of hypertension in at least 10 to 15% of patients, which is quite high. Especially in children, it is seen that 50% of the hypertension is due to secondary cause. And in young adults, less than 30 or around 30%, in age less than 40 years of individuals have secondary cause of hypertension. So that's why I would be discussing and briefing with a very common cause of hypertension, which is a cause of secondary hypertension, the primary aldosteronism. So here is the whole story. You can see looks very crowded. I make it a bit simple. We know there are two main causes, especially when I talk about the endocrine causes: the catecholamine by pheochromocytoma, and then mineralocorticoid excess. So basically the adrenal gland, which controls various hormones involved in the management of hypertension, and from that the catecholamines and mineralocorticoids are secreted. So when we can consider for pheochromocytoma or paraganglioma, if our patients with hypertension, they have a problem with paroxysmal symptoms, paradoxic BP responses, resistant hypertension, when excuse me, 3 or more of antihypertensives in maximum doses still are not able to control the blood pressure, incidental adrenal mass, previous paragangliomas, family history of paragangliomas, and some syndromic features which points towards pheochromocyte. And then for it, we do metanephrines, which are measured in blood or 24 hours urine. But today I will be talking about the primary aldosteronism, where there is mineralocorticoid effect. So there is a sustained systolic blood pressure increase above 150 and diastolic above 90. With resistant hypertension, as I said, not responding to 3 or more maximum dose of antihypertensives. And the hypertension is associated with hypokalemia, incidental adrenal mass, obstructive sleep apnea, family history of early onset of hypertension, or CVA at a younger age, that is less than 40 years, and all first degree relatives of patients with primary aldosteronism. So we should consider primary aldosteronism in these patients. And then there are other causes also where we can have mineralocorticoid excess, like excess of deoxycorticosterone in CH, especially the 11 beta or 17 alpha hydroxylase deficiency. Then we may have DOC producing tumors also. We may have primary cortisol resistance, where the cortisol keeps on increasing and causes hypertension. And then we have case detection of this also, where we need to measure the DOC level, 11 deoxycortisol, androstenedione, testosterone, DHEAS, cortisol, and 17 OHP levels. And I would be talking about this because it becomes very lengthy and sometimes confusing talking all these things in a single lecture. Then we have other causes also for secondary hypertension, like renovascular hypertension. We have other endocrine causes also, like Cushing's syndrome, hyperthyroidism, hypothyroidism, hypercalcemia, and primary hyperparathyroidism, and acromegaly. So these are some of the secondary endocrine causes. And then we have obstructive sleep apnea itself causing a resistant kind of hypertension. And this again, bit busy slide, we all know, so I won't go in detail. Here you can see the angiotensin 1, angiotensin 2, the renin, the angiotensinogen, the afferent, efferent arterioles, and this is all the RAS angiotensin aldosterone system, where we have ACE inhibitors working, ARBs working, and the inhibition of the aldosterone metabolism also, which is very well taken care by the aldosterone inhibitors or receptor blockers like spironolactone. And about these we will be talking in detail. But just paucity of time, I won't be talking much about these. So talking about primary aldosteronism, according to the European Society Guidelines 2016, this is a group of disorders in which aldosterone production is inappropriately high for the patient's sodium status. Because all these things you can see on the right side, the whole flow chart, the angiotensin 1, ACE, angiotensin 2, AT1 receptors, then we have aldosterone, where they act on kidneys and go for sodium reabsorption, which maintains the extracellular fluid volume. So basically, the You can see here the production of aldosterone is dependent on the hydrogen and potassium secretion and sodium reabsorption. So that's why they have said inappropriately high for sodium status. So even if the sodium status is normal, then also the aldosterone is high, relatively autonomous of the major regulators of secretion. So it becomes a autonomous secretion in spite of its effect or control by angiotensin 2 plasma potassium concentration, and is non-suppressible by sodium loading, because it is known that whenever the sodium goes high, aldosterone level should drop down. And here you can see these are some of the causes of primary aldosteronism, where the aldosterone producing adenoma is seen in about 1/3 of the patients with primary aldosteronism. The most common is being the bilateral idiopathic adrenal hyperplasia. And this hyperplasia produces more or autonomous aldosterone in spite of the control of the sodium, potassium, and angiotensin 2. Then we have lesser, very rare causes like unilateral adrenal hyperplasia, aldosterone producing adrenal cortical carcinoma, ectopic aldosterone producing adenomas, familial hyperaldosteronism type 1, 2, and 3. So again, coming back, why we are talking about this primary aldosteronism? Yes, because this is quite a common cause of hypertension, which is very easily neglected. Once thought to be a rare condition, just 1% of hypertension, and not worth investigation in patients with hypertension. This was long back. But what recent studies, retained data, they show that is quite common, specifically treatable also, and potentially curable form of hypertension. So see, we would be, if we diagnose somebody and treat the primary aldosteronism, we can cure the patient's hypertension, or else they would be suffering from it lifelong, along with a lot of target organs damage. And they account for almost 5 to 10% of all hypertensive patients. And in fact, in resistance hypertensive patients, the prevalence goes up to 20%. So you can see how common is this primary aldo. And these are some of the meta-analysis. You can see 2008, they say authors determined the mean prevalence of primary aldosteronism to be 9% in referred patient and almost 4.3% in primary care patients. So obviously, referred patients, definitely the chances would be more. But routine primary care, you can see almost 4.3% patients. And there is also elevated albumin aldosterone renin ratio, more so in referred patients compared to primary care patients. Again, 2012, the findings of the earlier 2008 meta-analysis again was done, and what it showed that the range of prevalence of aldosterone renin ratio was 7.5 to 32% in 2008, and 2012, after taking out all the confounding factors, it was 7 to 21%. And primary aldosteronism 2008, it was 6 to 24. Then current studies, the latest studies show 1 to 13.2%. in primary and referred patients respectively. So here you can see what I want to show, that this is quite common. Maybe earlier it was not sure, we did not have sensitive lab investigations, but now we have, but these have marginally changed. It still is a common cause of resistant hypertension. Again, in Journal of Clinical Endocrinology and Metabolism also showed in a systematic review and meta-regression analysis that it is pointless to claim low or high prevalence of aldosterone, primary aldosterone, based on the published report because of the heterogeneity in the population. But still they say prevalence in primary care 3 to 12.7% and referral 1 to 29.8 or almost 30%. So the high prevalence and long delay in the diagnosis of primary aldosteronism among patients with young hypertension. So here, this is basically a study done from India only to assess the prevalence of primary aldosteronism in patients with young hypertension less than 40 years for evaluation of secondary hypertension. And 18.8 patients screened positive and primary aldosteronism in young hypertensive were confirmed in 17.8% of patients. Their mean age was 43.9. Mean age of onset was 31 years. It means duration of hypertension 10.5 years. So the authors concluded that the age of onset of hypertension should also be included as a separate parameter to screen for primary aldosteronism. Again, some more data from India, but I won't go in detail. They say the prevalence is around 4 to 8%. So when we come to the clinical presentation, most common is 3rd to 6th decade. So at least in young individuals, less than 40 years of age, we should always consider primary aldosteronism as one of the commonest cause of the hypertension, sometimes resistant hypertension also. And hypertension, obviously, it occurs in most patients with primary aldosteronism. So, yes, the degree of hypertension is typically moderate to severe and sometimes resistant to usual pharmacological treatment. So, whenever this happens, we should definitely try to investigate for primary aldosteronism. In investigations, earlier we used to think that hypokalemia is quite common, but recent studies show that only 9 to 37% of RPA patients may have hypokalemia. And normokalemic hypertension is the most common presentation of this aldosteronism. So potassium levels should not be taken as really diagnostic. Less than 25% patients diagnosed with aldosteronism, less than 50% of those with aldosterone producing adenoma, and only 17% of those with idiopathic hyperplasia have low potassium levels. Obviously, we know the signs and symptoms of hypokalemia. So if our patient with resistant hypertension presents to us with nocturia, polyuria, muscle weakness, cramps, paresthesia, palpitation, sometimes paralysis also, then we should definitely consider primary aldosteronism. What are the clinical features here? Clinical features, a lot of problems in cardiac especially, along with hypertension and target organ damage, especially the heart and kidney. We have a risk of developing new onset diabetes also, with no known prior diagnosis of diabetes mellitus. So it may lead to heart failure, stroke, ischemia, end-stage renal dysfunction. Patients may have increased risk of stroke, MI, atrial fibrillation, increased LVH, increased stiffness of large arteries, widespread tissue fibrosis, and increased remodeling of resistance vessels. So diagnosis, when we come to diagnosis, this is basically three-step: the case detection, then confirmation, and then subtype evaluation. So when we come to case detection, according to Endocrine Society 2016 guidelines, these are the high-risk groups which are recommended to be screened for primary aldosteronism. Sustained BP above 150/100 mm of Hg on each of 3 measurements on different days. Resistant hypertension more than 140/90 on 3 conventional antihypertensives, including a diuretic. Even a controlled hypertension less than 140/90 on 4 or more antihypertensive agents. Hypertension with hypokalemia, hypertension with adrenal incidentaloma, hypertension with sleep apnea, hypertension and family history of early onset of hypertension, or a CVA age less than 40 years, and obviously all hypertensive first degree relative of patients with primary aldosteronism. So what we should do for these patients? Quite simple, easily available tests now: paired measurements of plasma aldosterone concentration and plasma renin levels in a random morning ambulatory blood sample. The aldosterone-renin ratio is currently the most reliable means available for screening, and this obviously is not without false positive and false negative. So therefore these should be regarded just as a detection test and should be repeated if the initial results are inconclusive or difficult to interpret, or if PA is strongly suspected clinically, but the initial screening results are negative. So both the things can happen. Depending on the patient situation, we can decide. What are the factors which can contribute to false positive and false negative? Aldosterone-renin ratio, false positive, beta blockers, sympatholytic drugs, NSAIDs, OCPs, luteal phase in female, advancing age, CKD, high dietary sodium, high potassium. For false negative, we have diuretics, ACE inhibitors, ARBs, dihydropyridine CCBs, SSRIs, pregnancy, vomiting, diarrhea, malignant hypertension, low dietary sodium, and hypokalemia. What are the approaches for ARR measurement? It is most sensitive when samples are collected in the morning after the patients have been out of bed for at least 2 hours. Usually after they have been seated for 5 to 10 minutes. Try to correct the hypokalemia before. Ask the patient to liberalize the salt intake, withdraw all the agents which can affect, as I have shown you in the last slide, which can affect the ARR levels. And if the results are not diagnostic, and if the hypertensions can be controlled with relatively non-interfering medication, withdraw medications for at least 2 weeks. And if necessary, to control the hypertension, we can give our patients alpha blockers, verapamil, or hydroxyzine. And what is the assay reliability of aldosterone and renin? Yes, aldosterone is also influenced by many factors. We earlier were doing by RIA methods, but now we have automated immunoassays or LCMS, which are more specific, but we need an international standard. But now it's quite easily available. Renin also, the plasma renin We had earlier enzymatic kinetic assay, which was cumbersome, but then now we measure the activity of renin by levels of angiotensin 1. Then we have DRC also, and we have, but we don't use it that regularly. We basically use aldosterone and the PRA. And these are the current thresholds. I won't go in detail, but here you can see according to the aldosterone in nanogram per deciliter and aldosterone in picomole per liter. These are some of the conversion factors or conversion of screening test. Then what are the confirmatory tests? According to the Endocrine Society guideline, positive ARR should undergo one or more of the confirmatory tests to definitively confirm or exclude the diagnosis. So we have ARR, which is affected by a lot of confounding factors, but as long as we see a renin level which is quite suppressed and a plasma aldosterone concentration which is above 10, confirmatory tests can be done regardless of whatever the medication patient is saying. So the ratio, the ARR ratio, if it is quite significant, and if some medications were interfering also, then also it does not matter. So what are the commonly used testing procedures or confirmatory? Oral sodium loading test, saline infusion test, fludrocortisone suppression test, and captopril challenge test. These are the procedures. Correct hypertension, correct hypokalemia, high sodium diet for 3 days, and then collect 24 hours urine sample on day 3 for urine sodium, creatinine, and aldosterone. Then we have saline infusion, recombinant position for 1 hour before and during the infusion. Some studies, they say sitting position, 2 liters of 0.9 normal saline over 4 hours, starting around 8 to 9 a.m. At the completion of infusion, blood is drawn for measurement of plasma and aldosterone concentration. Then we have these diagnostic cutoffs. 24-hour urine sodium excretion should be more than 200 milliequivalent, so that we know that patient all has adequate sodium repletion. If the urinary aldosterone excretion goes more than 12 microgram per 24 hours, yes, this is positive. The sensitivity and specificity is 96% and 93% respectively. Yes, there are contraindications in patients who have uncontrolled hypertension, renal insufficiency, cardiac arrhythmias, or severe hypokalemia. Saline infusion, PAC less than 5, PA is unlikely. PAC more than 10, PA is quite likely. And if it is between 5 to 10, it is intermediate. And obviously, the contraindication remains same. So you can see here oral sodium, saline infusion, and the PAC values also. Then we come to fludrocortisone. 0.1 mg oral fludrocortisone every 6 hours. NaCl supplements, maintain normokalemia, and plasma aldosterone and PRA are measured at 10 a.m. on day 4 in sitting position. And here, if PAC is more than 6, suppressed renin, on day 4, it is suggestive of the primary aldosteronism. Captopril challenge, not commonly used nowadays. 25 to 50 mg of captopril orally, sitting or standing for 1 hour. Measurement of PRA and PAC at 0, 1, and 2 hours after the challenge in sitting position. Normally, more than 30% of the plasma aldosterone is suppressed by captopril. But if it goes above 15 nanogram per deciliter at 2 hours, it is highly suggestive of primary aldosteronism. These are some of the confirmatory tests. Now, because of paucity of time, I won't be going in detail of subtype classification, because we need to lateralize this source, which adrenal is involved, to guide in the management. Then we have to have a distinction between unilateral and bilateral. because in unilateral, we can go for adrenalectomy in all patients. But if these are bilateral, we have to go for more of medical management, and seldom we may require bilateral adrenalectomy. So initial investigation, we should go for CT adrenals, but most accurate and gold standard is adrenal venous sampling. So this is CT. There are some limitations also. CT has got sensitivity and specificity in localization or lateralization of 75 to 78%. Then we have adrenal venous sampling, which is gold standard to distinguish between unilateral and bilateral disease. So this is the venous sampling. About the studies, non-invasive methods also we have 11C metomidate scan, we have CXCR4 ligand bag PET scan, then 18F PET scan also are available, but I don't have much idea about these. Treatment, unilateral adrenectomy, we can go for this thing. Post-surgery, we can collect plasma aldosterone on day 1, day 2 to confirm biochemical cure. Full assessment should be done at least till 3 months post-op. Potassium should be checked every week, and we have to explain the patients also that there are some times that hypertension can be cured fully. And these are some of the studies which show the outcome assessment. I won't go in detail. Coming to the medical treatment of primary aldosteronism, sodium restricted diet, drug of choice is spironolactone, 50 to 400 mg. Hypokalemia corrects promptly and the blood pressure may take 4 to 6 weeks to correct. If patient cannot tolerate spironolactone, eplerenone can be given maximum dose of 100 mg. Because sometimes patient may have gynecomastia with spironolactone. We can use eplerenone, but the efficacy of eplerenone compared to spironolactone is quite less. These are some other causes like pseudo-hyperaldosteronism. I won't go in detail. Syndrome of apparent mineralocorticoid excess. So to conclude, primary aldosteronism is not an uncommon secondary cause of hypertension. Low threshold and high index of suspicion for case detection should be there in high-risk individuals. And aldosterone-renin ratio, if unequal or negative in setting of high clinical probability of aldosterone, should be repeated. And then proper test should be done for lateralization or for the unilateral or bilateral disease investigation, and the AVS is the gold standard for lateralization. Thank you.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one. I definitely think this session knowledge is going to help all the participants who have joined this session. Sir, I can see we have received some question from the participant. If you allow, can I take this question with all your permission?
Please.
First question is from Dr. Agarwal. He is asking, what are the clinical manifestation of PA-induced hypertension and how can be these symptoms help in its diagnosis?
I think, Dr. Agarwal, most of the symptoms, as I said, are related to uncontrolled hypertension and target organ damage. Only, as I said, few patients may have hypokalemia related symptom, because hypokalemia itself is, you can see, not more seen in more than 1/3 of the patients. So hypokalemia can give us a clue. The uncontrolled or resistant hypertension can give us a clue. At people age younger than 40 years can give us a clue. And you can say uncontrolled hypertension in spite of using 3 or more antihypertensives can give us a clue to investigate or look for a primary aldosteronism.
Thank you so much, sir, for answering the question and explaining it really well. Moving forward, I can see another question from Dr. Subramaniam. He's asking what are the current guidelines and the best practice for the long-term follow-up of patient with PA-induced hypertension, including monitoring and adjustment of treatment.
Yes, yeah, it is quite important question because a lot of times we start treatment also of primary aldosteronism along with other antihypertensive medications, but it is usually seen that these people, the hypertension sometimes stays it because of the target organ damage caused by the high blood pressure, the hypertension, whatever the vascular changes have occurred, they sometimes become permanent. They don't go off. So the hypertension becomes quite chronic or maybe a lifelong. But yes, if we control primary aldosteronism well with drugs like spironolactone, patient taking them regularly, we may go for monitoring of the electrolytes once in 6 months or once a year according to the patient's condition. But otherwise, our target should be to continue spironolactone in our antihypertensive drug prescription and taking care of target organ damages as and when required.
Thank you once again, sir, for explaining it really well. I can see one last question for today's session from Dr. Shruti. She's asking, how does the management of PA-induced hypertension impact patient outcomes, including blood pressure control, cardiovascular risk, reduction, and quality of life?
Yes, Dr. Shruti, very good question. In fact, as I said earlier also, that it is one of the commonest cause, almost 1/3 of young hypertensives, less than 40 years of age, may have primary aldosteronism. And if we diagnose it at a very early stage, treat it properly, manage it well, there are cases seen, a lot of cases seen, in fact, where the hypertension totally resolves with only the use of spironolactone. And there is very minimal target organ damage to our patients who are quite young. So we should be very active and very, you can say, aggressive in especially young individuals who have got high blood pressure levels. If we really want to take care of them, or even we may cure them of hypertension if diagnosed early and treated properly.
Yeah, thank you so much, sir, for clearing all the doubts of the participant doctors. As I can see, sir, there is no more question from the participant end, but Dr. Shruti has written wonderful presentation and thanks for answering my question.
Thank
And
you,
I
madam.
hope that it was a really interactive session from your end, sir. As there is no more question, with all your permission, shall we conclude this session?
Thank you. Thank you, everybody.
Okay, sir, we are closing this session for now. Hope to see you again with different topic in coming time, sir. Till then, take care of yourself and happy